We do have a wonderful reception following today's event. It'll start at 4:30 in the same room. A cocktail reception followed by dinner and wonderful an evening together. And I'm sure all the speakers will be available and you may continue the discussions tonight as well. On with the program. We have all our speakers here and almost ready. I would like to introduce the next speaker, Dr. Xerxez Calilung. I think I deserve an award just for pronouncing his name. He graduated from the dental school at University of Southern California and is an associate professor at USC. He's the past president of the Orange County Dental Society and the California Dental Association Peer Review Council, and has a long service in same. But as I did tell you, I asked everybody to tell me something quirky about themselves, and I twisted around a little bit. His hobbies is buying exotic cars and donating them to me, as of today. But I believe from today I understand that he's not the smartest guy in his house, because his daughter is graduating from a residency in dentistry this year. So without further ado, Dr. Calilung, please.
Thank you very much, everyone. We were gonna, sorry for the switch up, but we were gonna start the stem cell update starting from the top of the head to the mouth to the this area and down here, and then go back up to the brain. But I'm happy to be here to kind of update you on the dental guys. And it's like, what are these guys doing with the stem cells? The cool thing is when the stem cells go into the body, and especially in the mouth, it doesn't know that it's going in as a dental procedure. And sometimes, even though that we talk to it and it says, okay, you're only supposed to do dental things, okay? Because my scope of practice is head and neck and associated structures. But as you all of us know, it kind of does its own thing. And it goes after the things that are always affected. And the thing that I do different in dentistry is I don't do IV. All my stem cell introduction is all in the oral cavity, strictly subcutaneous, and the sublabial fold, both in the top and the bottom of the teeth. And if you take your finger, a clean one, and stick it into your face, and then you kind of poke up, and then if it stops, that's the place where it goes. And then take another clean finger, and then put it on the bottom, and then from the outside of the teeth, and when you push down and the skin stops, then that's where you go. So you guys have been having this primer in terms of the stem cells. Everyone already knows what this thing does. It replicates. So my introduction to stem cells was back in 2009 when I met Habib, and I was actually doing fat stem cells, and we were harvesting it for my patient. And to the chagrin of my patients, it says, well, how am I gonna get the stem cells? I says, well, you just gotta go and lay down, and we go suck the fat, and we process it, and then we stick it back into your face. And it goes, oh. And out of about 1,000 people, I may get like one person say, yeah, I'll do that. So it was okay, and we didn't get a whole lot of takers. We got a couple of guys, but it didn't do any. I didn't see anything that it was doing for me in terms of dentistry. And come 2000, about a year ago, and the biggest miracle was that Habib. May I say something? May I share that with you? Biggest miracle is Habib got a toothache, and he had to see me. And he had to go get an implant. And I said, Habib, you do stem cells? Let's put some stem cells into your face. And I am proud to say that I am the first guy to stick stem cells into his face, into his body. And so I'm just curious, how many people in this room have had stem cells? And so cord blood was my first, fat stem cells was my first introduction. And then cord blood was my second introduction. And then amniotic fluid was was the following one. And then Wharton's jelly was my next one. Now, for a lot of you here, Wharton's jelly was probably your first introduction to stem cells. Well, I'm sorry, maybe PRP. So I'm going to talk to you about why I choose Wharton's jelly as opposed to cord blood, as opposed to amniotic fluid, and also as opposed to some combination of such all three. And so the first thing out of my patient's mouth is like, does it come from babies? Are they dead? Are they alive? I said, no. He goes, we only go from the bottom. The bottom line is, and they said, okay. And the next thing is, well, where does it come from? Blood and tissue. So part of the issue is that there's a lot of discussion in terms of putting IV, because if you ask me, he goes, I'm the intraoral guy, and so I always goes like, IV, come on, man, that's just like so like 2018. Intraoral, 2019 is where it's at, and I am gonna. Half of you guys won't like me, and half of you guys will, and I'm gonna just change my mind in terms of why I think intraoral introduction is maybe a little bit better than the IV introduction. Well, first of all, is the tissue. There was always an issue with the tissue being so thick that it causes embolism. Is that right? I says, well, we use a filter. I said, okay. And there's some that don't use any filters that they said, I'm alive, so it must work. Well, I'm not really willing to take that chance. And that's why the cord blood stem cells have been doing really, really well, is because there's no issues with that. Now, what about the possibility of DMSO and having an allergic reaction, and we got to get out the crash cart, and everyone's all up in arms, like, oh my God, it's like this guy's not going to breathe, everything's horrible. Well, I'm just here to tell you that 25 milligrams of Benadryl 30 minutes prior to any kind of introduction, whether it's IV or intraoral, works just fine. I have a lot of my patients that are very, very allergic to the sulfa, and I've had very, very little concerns in terms of that. And then later on that night, they'll take another 25 milligrams and they'll just have a great night's sleep. So why cord blood as opposed to cord tissue with the Wharton's jelly? I deal with facial pain, and I deal with inflammation, blood, structures, and everything like that. My first thing is, so if people ask me, what do you do? I'm a dentist. It goes, what do you do? It goes, I do root canals and crowns. Root canal is pain, crown is looks. And the cool thing about these stem cells is it kind of addresses both. It addresses the pain, modulates the pain, and as far as the looks, I happen to be blessed that I work in an area that's kind of occupies the face. And in the face, there's two sides to the face. There's the outside, where the plastic surgeons like to do their microneedling and do all those things that are cosmetic. But the cool part is, anytime I make a hole on the inside, nobody sees it. And it kind of works pretty cool. Now, again, this is the same thing that where we tell the stem cells, okay, guys, only do dental things. Don't do any medical things, okay, because that's not my scope of practice. But unfortunately, there's a lot of really, really cool side benefits that kind of come along with this stuff. Because of cord blood, while I was addressing a dental situation, we have comorbidities of eye diseases being helped, like macular degeneration, diabetic neuropathy, field of vision issues, and nearsightedness and farsightedness. And the recent article of the AARP addressed that stem cells are basically going to be curing blindness. And it's the November-October issue of AARP, if you guys are really interested in that. I started with cord blood, I went with amnio, and then I went with Wharton's jelly. Wharton's jelly is kind of cool. Wharton's jelly, after a spectrograph of a sample, both cord blood and Wharton's jelly, I'm going to show you some pictures that I think you guys are going to like. This is a spectrograph of United States, California, Southern California, Irvine, Balboa Bay Club. Okay? So you see, there's a huge population of the kind of cells that we want in terms of the stem cells. Here's Wharton's jelly. Balboa Bay Club. Bunch of them in there. A lot doing a lot of stuff. And so I don't know if this is going to change the way you think about cord blood and as opposed to Wharton's jelly, but I think for pain and modulation, I think I would go with cord blood, and I'll tell you why in the next slide. But just in terms of the comparing apples to apples in terms of the numbers, it's definitely significantly higher in Wharton's jelly than it is in cord blood. Now the thing is, some of them they're different. They're like long distance runners, some like mid distance runners, and then short distance runners, and they're specialized in terms of what they do. And I think it's really up to you in terms of what you think these specialized cells are going to be able to address in terms of your practice and where you do it. The gray zone is the amniotic fluid, the orange is the cord blood, and the Wharton's jelly is in the blue. And again, this is a logarithmic scale. And so, you know, the ones up in the top are not just that much better, but logarithmically better. But if you look at it and address all the anti-inflammatory and the wound healing and the growth factors and the homeostatic factors, that amniotic fluid is just through the roof. And it was because of this that I started thinking in terms of how I do my stem cell therapy. With my cord blood, I will actually add amniotic fluid after or before. And so it's like, do you send in the reinforcements, the supplies first before you get the paratroopers to come in? Or you put in the paratroopers, then you send in the reinforcements and the ammunition and everything to go ahead and go after the battle? I don't think it matters, but I kind of like to do the amnio first because it modulates all the inflammatory responses and it doesn't hurt so much. One thing about the cord blood stuck in the head is it gets really, really cold, really, really fast for about 60 seconds to maybe 2 minutes. And so I tell my patients, it's like, do you want really cold or really dead cells? And they said, oh, no, really cold's fine with me. He goes, if I'm gonna be paying this much, he goes, stick it in. And I have no problems with that. And usually after 60 seconds to about no more than 2 minutes, the pain is gone and everything is fine. Any questions in terms of the comparisons? Oh, by the way, when I was doing cord blood stem cells for trigeminal neuralgia pain, there's two types of trigeminal neuralgia. There's TN1 and TN2, and TN2 is constantly on, 24/7 for like the last 15, 20 years. And then there's the TN1, which is the sporadic one. It's usually caused by some kind of compression against a nerve. It's some kind of anatomical issue that's going on. TN2 is the one that cord blood stem cells works within 20 minutes. I'm going to say that again. It works in 20 minutes. My patient who has been in pain for the last 20 years, after one injection of the cord blood stem cells, the pain turned off, and it stayed off, and it's been off for the last 5 months. I have patients with trigeminal neuralgia 1, which is the one from compression. It takes about 3 to 4 months to actually help them out, but there's still a physical problem with the nerve, and there's still the compression. While it might be able to reduce the pain, I still think there's going to be a problem because there's a physical problem, and the stem cells just, they can't do the structural fix. They can do a remyelination probably of the nerves, but it just doesn't do a structural fix. But it does help, and it helps them significantly in terms of what's going on. Again, these are the markers in terms of before. Inflammatory markers, inflammatory markers, inflammatory markers, anti-inflammatory markers. And within 5 minutes, within the cord blood, it drops down from 95 to like 5%. Amnio fluid does the same thing too, I think. Everything that I do is basically pain, people in pain. It's just like, just get me out of it. Headaches, TMJ pain, trigeminal neuralgias. Again, I talked to my cells and said, please stay dental. But it just kind of just does this thing, and I have a feeling that these cells travel through the lymphatic systems, and they just kind of move around, and they take care of like knee pain, joint pain, ankle pain, pretty much everything that you can think of. And then these are all the the types of neuropathic pain that it's been doing. All these psychotic drugs, it just dulls people. It just turns them into zombies and kills the liver and the kidneys. And I follow these groups of trigeminal neuralgia groups, and they just want to jump off a window and jump off the roof and just to kill the pain. And I really think we have a charge to, one is, it's like, why stem cells? And I really think one is to stop the opioid use in America. And the second is to really reduce the steroid use for the inflammation. And I think if all of us can do those things, and just in terms of helping our patients, I think that's really a noble thing for us to do. This is my aunt. Last Sunday, she got Bell's palsy. The trigger probably was a viral trigger. And so she came and went to the doctor and got antiviral medication and steroids. And the doctor says, oh, you should be okay in about a couple of weeks or a couple of months. I go, a couple of months? He goes, you're going to make my aunt look like this in a couple of months? I said, Auntie, come on over. 1 shot of amniotic fluid, 1 cc, delivered intraorally in the buccal fold and on the Bell's palsy side, and within 1 hour, you got from this one to this. She had her motor function back, but she didn't have the feeling back. I called her again today. All the motor function and feeling is completely done. Everything's good, 100%. No dental thing is complete without a dental x-ray. And so these are all with cord blood and without amnio. And so what I'm trying to say here is that these teeth are basically hopeless. And I said, we can pull your tooth, or we can try to go ahead and put some stem cells and maybe just keep it around for a little bit longer. I had sent her through every single thing in terms of like root canal and root canal specialist, and the root canal specialist says, if you can't do anything anymore, just pull it out. And she said, no. We put it in. These things have zero mobility, and it's about as strong as can be with zero pain. This is a cancer patient. Go ahead, please.
Was there any bone graft with
None.
just straight?
None whatsoever. Just cord blood directly into the buccal fold. 1 cc. And so, and this one was, he's undergoing some cancer therapy, and he says like, just make my tooth last longer. And he had a lot of pain. And but what you see here is just within like a couple of months is, again, some more bone regeneration in the area. And this is with cord blood. And I think if I would have changed into the Wharton's jelly, I think I would have had much more significant gains in terms of like the bone and the tissue and every structural item in that area, I think, would have been much, much more. And so with this one, what you're looking for is the white band right here. This thing is like a three-dimensional void that I can't fix. Because I need at least one wall to be able to fix something, and I just can't fix anything like that. But this one I had 3 walls, and that's why I was able to get some bone regeneration. And the thing is, there was nothing special about this thing. I just placed the stem cell. Again, this is cord blood, and I really think I would have done better if I would have done with Wharton's jelly. That's because of the spectrograph that I showed you a little bit earlier. And this one, this tooth on the left-hand side was completely going to be gone. And so just in this short term alone, we got full regeneration of the bone directly all the way to against the tooth. And what I'm trying to say is that, the teeth, again, cells don't know what they're supposed to do. And I'm just telling you, as there's an alternative to IV introduction, and also a site in terms of all the joints. But the head is a very, very viable point of entry for the stem cells, and also a point of distribution in the stem cells. And I really believe that it's also through the lymphatic systems that it gets distributed. And but I appreciate your time. This is the stack of what do you call that, release forms from my patients. And I have ones from trigeminal neuralgias to the eyes and gum recession, but it's not. I'm speaking to the choir, and you guys wouldn't be here if you guys didn't believe in the promise and in the magic of the stem cells. And I just do appreciate your time and your attention, and thank you very much for having me.
Just a little change of hardware for Dr. Salas's talk, and while our handy technicians do that, it's a train of them. Let me introduce Dr. Sara Salas. Dr. Salas completed her dermatology and specialization in Mexico, and did a hair restoration subspecialty in the University of Tel Aviv in Israel with Dr. Ginsberg, and completed several fellowships in USA, Canada, and Paraguay. She's a member of the International Society for Hair Restoration Surgery and the World FUE Institute, dominating the 3 techniques of hair restoration, hair transplant. There's an alphabet soup here. I don't know whether it's vulgar or not, but FUT, FUE, including the long hair FUE. Obviously, she's a friend of mine, but I've never met her professionally.
It's a pleasure to be in here. I think that we are very excited about learning all the things and the possibilities that we can have for ourselves. When I see these kind of talks, and then I'm going to have a therapy. Also for my problem in the jaw. When I found out in our previous meeting, and I was like so excited about all the things that we are learning today. And thank you for coming. And I'm a dermatologist, a hair restoration specialist, and stem cells has been a very, very important, not only the stem cells, but the growth factors to the topical preparations in my practice. And my patients are very happy. I'm gonna show you some cases. So we know in hair that every time that we have, especially in androgenetic alopecia, and that we have miniaturized hairs, when we're thinning, we all gonna thin with age. When the aging process is where we're having that, we have our thinning process going on in the hair, so the hair becomes thinner, thinner, thinner until it disappears. So we can stop that, and we can regrow that hair back to a stronger, darker hair. So we know that the stem cells can form any line of cells. That's why it's the mother of all the lines of cells. So that's why you're looking to all different applications of stem cells. So when we started to put in the scalp was to help these kind of patients that they can regrow hair, but needs to be something there. So it's not like we don't have any and then we're gonna put it, then it's not the case. But if we are looking and with the microscope and we can see the follicular ostia, which is the pore with the sebaceous gland, that even if we don't see the hair but it's open, we can regrow more hair. So, so I explained to my patients that in the hair we have two sites where we can find the stem cells. One is at the level of the bulge, which is the area there near the erector muscle of the hair, and also at the root. So it's very important that when the hair is damaged, the hair around the damaged area, and that is something that they prove already. The stem cells from the other hairs migrate to those hairs to help. So if we can reactivate that scalp and help these hairs to regrow, to become more active and more stronger, so we can do that with the application of the stem cells. So we know that we have 3 stages, and any of these stages can receive problems. Can be a telogen effluvium, can be an anagen effluvium, where is what is happening with cancer patients, that they lost all their hair because of they hit this stage where 80 to 90% of all our hairs are in this stage. So so that's why after they complete their treatment, we can do something about to help them. And so there's a lot of applications. We need to know that in the hair of the cycle, we can stimulate and we can kind of help the cycles to accelerate, to go to the resting phase or the to the growing phase. So in stem cells, we know that when the stem cells goes into the scalp, it's starting to activate in producing all these growth factors. And these growth factors are, some of them contains a product, the Reluma product. I don't know if you're aware, that you know about the Reluma product, but Reluma product contains growth factors from stem cells. So we can use that in topical preparations and starting to help those patients. And then if the patient needed, we can go a step ahead and then we can apply stem cells. So it's important. I always like to show my patients what stem cells looks like, and it's a wonderful world. That this morning I have a patient that flies to see me at 7 a.m. and he was like, "But why we can't find this? If it's so wonderful, the stem cell therapy, why is not everywhere? Why the doctors are not talking about this more often?" And he's a person that searched a lot, and it was hard for him to find accurate information about that. And I said, okay, send me an email. I will send you the articles about these therapies. And and he's right. Why we're not talking about this? Why is taking so slow to convince us about what we can do with stem cells? So there's been in the hair world, it's been publications regarding this topic, which is alopecia areata. And alopecia areata can be, we can have a family predisposition, but mainly it's when our immune system starting to attack our hair and doesn't recognize our own hair. So it attacks the hair. So it can be a lot of presentations, can be just small patches, or it can be the entire scalp, which is alopecia totalis, or can affect the entire body. So that is alopecia universalis. So in this publication, they did an application of cord blood stem cells IV, and in 9 patients. So it was one treatment, and the patients starting to regrow the hair. This is one of the examples of this study, and this lady was with alopecia areata affecting their entire scalp, as you can see the before treatment. And then 4 weeks, how the hair is starting to regrow. We know in alopecia areata, it's not in hair, we have 2 kinds of diseases that affect the hair. We have the scarring alopecias and we have the non-scarring alopecias. We can treat with stem cells the non-scarring alopecias because once we have a scar tissue formation in the scalp, there's nothing that we can do about that. But if it's one of those diseases like this, autoimmune diseases, alopecia areata, lichen planopilaris, lupus, or androgenetic alopecia, which is not an autoimmune, but is one of the non-scarring alopecias, we can do something about it, and the sooner the better. Because once the follicular ostia is closed, so we can do anything at that stage. So this lady with just one treatment, and it was 8 weeks and 12 weeks, and then 40 weeks and 2 years after, she kept the hair. So I think that this is something to look for it. And when I'm receiving a patient in the consultation, I always need to follow like everything, my consultation. I need to classify my patient. I need to see in which stage my patient is, and see and evaluate if there's any miniaturized hairs. For example, in the first photo, we can see some thinning hair in the front. We can have, it's only their temporal recessions, it's the crown, it's ruling out any scarring alopecias, which is very important, and also to evaluate the donor area. I'm a hair transplant surgeon, so I always looking for which options can I give to my options. Am I gonna give him only medical choices, surgical approaches only, combination stem cell therapy, or the 3 of them? The majority of my patients, when they come in at the early stages, they're candidate for 3: medical therapy at home, and then surgical approach, to recover, to add density, recovering the look that they used to have if they have a donor area. And also always, if the patient has a lot of miniaturized hairs, then I add stem cells. So especially in this photo at the bottom, the hair was terrible thin in the donor area. The area to be covered was very large. So we need to evaluate what we're gonna do and have options with the patients. In this article, what they did is they applied stem cell therapy, and they have an increase in the hair density and also the thickness of the hair. You can see here the before and after photos, and especially in a woman, when we tend to lose our hair in a more diffuse way, meaning the entire scalp, we are less good candidate for hair restoration compared to a man that tend to lose the hair on the top, but the donor area is intact. The woman, we tend to lose our hair everywhere. That make us less to not very good candidate for hair restoration. So that's why we need to give options to the patient. In this other study, they did this study with these mouses, and they controlled, they didn't do anything, and then they inject the stem cells, the adipose stem cells, and then in the other one, topical. And then they have a regrowth of the hair at 4 weeks. So they're starting to look for this, and to starting to apply it in the humans. So the adipose stem cells, we're also using it thanks to Habib and their wonderful group. And we're using right now cord blood stem cells or adipose stem cells with the help of a plastic surgeon that do the liposuction, and then they give us the fat, and then we extract the stem cells from the fat. Habib sends his team, and then we produce, if the patient wants, his own stem cells. So this is another article. They use the adipose stem cells, and what they so it was a follow-up at 7 months. We can see here an increase in the thickness of the hair. So this is another of the photos of the article. So we can see how this woman's starting to do that. So in our practice, in topical preparation, I always leave my patients with growth factors in the form of a shampoo and a lotion, which is Reluma shampoo and Reluma growth factors. And then I add to the medical therapy, I add stem cells. For example, with this patient, we did a session of stem cells. So we can see at 5 months how the hair starting to look darker and thicker. This is another view 5 months after. So we're starting to see this. Normally, if a patient is only going to have, of course, this is a patient also candidate for hair restoration, but only wanted to, this patient only choose stem cells. So from the back, you can see the crown starting to become less visible. And so this is one of the options. This was cord blood stem cells. So then we decided to do a combination of adipose stem cells because the patients wanted with hair transplant. So in this patient, I add first the stem cells, and then I did the surgery of these grafts. Normally, when we do surgery, the graft will start to regrowth in the new place at 3 months. So here we can see the before. After 1 month, you can see how the hair was thicker and it was more dark. And at 4 months, the miniaturized hair that the patients had before, because what we did is that the miniaturized hairs were here, and we add density with the hair transplant. So we did the stem cells, then we did the surgery the next day. So and then we started to see the improvements a couple of months after, so saving 1 month before of what is normally we can expect it to have it at 3 months. And you can see here at the crown how the crown's starting to cover and at 4 months. So it's important that I didn't do anything in the crown. My grafts, I put it in the front and mid scalp, and so now I'm going to do the crown for hair restoration. But the stem cells help us to have a better coverage of the hair. I don't know if you can see this area, the lower area, and that is the hair. It's thicker and it's increasing the density and the thickness of the hair. So then this patient didn't want any injections, anything. So the wife wanted to do something. I was like, okay, but he don't want needles, he don't want anything. Okay, topical preparation. So we decided to leave him with Reluma. So this is the effect of 5 months after starting with Reluma. So you can see that even the tiny miniaturized hairs starting to regrowth, and the patient, this is January, then February, then June. So this is the fact, and this patient was like, oh, let me see again the photos, let me see again the photos. So he was so excited that it was like just a topical preparation. So I think that, I mean, it depends on the expectations of the patient. If the patient wants more, we can offer everything like hair transplant plus stem cells, and they continue with growth factors in a form of Reluma products after the hair transplant. But there's some patients that they're happy with having a little bit more, which is okay. It depends on the patient. So, but here, for example, the crown, which was the area that the last area to become thinner, so we can have a better result with just the topical preparation. So this was just topical. When we're going to combine it with hair restoration, and when we want to combine it with hair restoration, we need to give options to our patients. So it's important that in our practice we have 3 kind of hair transplant that we can do, 3 techniques. One is the strip method that I don't know if you're aware of, but we remove a strip from the back of the head. It depends how many grafts do we need. And then we divided that whole strip in tiny slivers. And then we prepare the grafts under the microscope. We remove all the fat. And then we divide the tiny strips into individual follicular units, which are the grafts. So then you can see up there all the greasy, the fat. We separate. We don't transplant fat or skin. You don't need it. We just need the graft. And then we separate all the grafts into families of 1 hair, 2 hairs, and 3 hairs. Rarely we have 4 hair grafts or 5 hair grafts. So we divided that, then we hold it in a special solution to maintain these grafts alive in a cold preparation. So we keep track of every single graft that we are gonna cut, and then we prepare all the area that we're gonna put, and we create the sites of where it's gonna be the grafts. And then once we have the incisions, if we're gonna do 1,000 or 3,000 graft session, we're gonna create 1,000 or 3,000 grafts, 3,000 incisions. In every one of the incisions is gonna be one graft. And so it's, then we do the implant. So we do it one by one. So yes, it depends on the session. It's gonna take us 6 hours or 8 hours or 12 hours. So it depends, and it depends also in the technique. So after all the grafts are in place, so at the end, we give the directions that we want to the hairs. We give the direction. If we want to go this way, that way, this way, very, very acute angle. And it depends if I have some hair to guide me, then I follow what the patient already have, those miniaturized hairs. This is how it looks 2 weeks after when I remove the stitches. So we don't need to shave the head with this technique. So now this is a technique, FUE is follicular unit excision, and this is for patients that use the hair very short. And this is a technique that will remove individual follicular units. So there's no stitches involved. And again, it's for patients that use the hair short, or the patient that doesn't have good elasticity, or patient that had a previous surgeries, or they just don't want a line in the back of the head. So if they don't want a line, or they're not a good candidate for strip, then we offer FUE. In FUE here, we are extracting individually the follicular units. So I can see if I need how many ones, how many twos, how many 3 hair grafts do I need, then I can choose them from the scalp. Here I'm creating just the separation of the grafts, and here we're doing the extraction of the hairs. So yes, this is a technique that is gonna take us longer, and the only difference between the two techniques is the way we remove the hair from the back. We're gonna remove it in a form of a strip, or we're gonna remove it in a form of individual follicular unit. But the way I create the incisions, the way we implant grafts, everything, the result at the end of the day is going to be exactly the same. The only difference is going to be the way we remove the hair from the back. So there's different kind of alopecias, there are different kind of patients, and we need to give options to our patients, men, females. I have also very young adults that they have scars from previous accidents, or they born with some defect, so we can fix that. So these grafts in FUE are more delicate. We're using 0.8, 0.9 sizes of the punches to extract it. So these grafts are very, very delicate. So the process is it's a little bit slower, but it's for some patients, it's worth it not to have a line in the back of the head. So I give these options to my patients, and I always leave these patients where we are doing surgery to grow factors after the surgery. Right now, you're gonna see how it looks at the end of the procedure. So once we implant everything, all the grafts are gonna be in place. Of course, the patient has a short haircut with this technique. And then from the back of the head, it looks like a lot of tiny holes. And you can see right now how it's gonna look, how we distribute the holes in the entire scalp, and then one day past the surgery, you can still see some red dots, but those dots are not wide open, so they're starting to close. So I always leave with growth factors post the surgery, and this is helping us with the recovery of the patients. So this is our some before and after, and this is how it looks, the donor area before and after, like nothing happened. And if they trying to look for the dots, they're not gonna find it. So for FUE, there's a new technique, which is the FUE with long hair. And in this technique, we don't shave the head. We go in between the hairs. So this technique is for patients that they want FUE, they don't want to have a line, they don't want stitches, but they want this freedom of cutting the hair if they want it shorter or leave it longer. But they want hair, but they don't want to shave. I never shave in my life, so I don't want to shave, but I don't want to strip. So then this technique is for those kind of patients that they want the hair, but they don't want to shave. So the way we do it is we do the extractions in between the hairs, and then we extract the same way the graft from the scalp. As you can see here, we remove it very, very delicate. This technique, it takes us longer because we have the hair in our way, so it's not like we have a shaved scalp and then we can go faster. So in this one, I have the hair in between, but you're gonna see how the patient looks after. So with these hairs, we remove the hair with long hair. The patient at the end of the surgery, they're like having the long hair in the front and in the donor area, but the recipient area is gonna have the graft with the long hair, and the donor area is gonna look like nothing. You're gonna see in a second. So we are gonna organize the graft the same way that we're doing with all the other techniques, and we count every single one of the hairs, and so it's also a little bit slower because the hair is in the middle. But at the end, the patient, you can see here that we group again all the ones or the 2 hair grafts and the 3 hair grafts, and the same way. So after the extractions, everything is the same with the 3 techniques. But again, it's another option to the patients, and the patient at the end of the day, they can choose which technique they wanna choose. This is how the patient looks right after the surgery. So I extract the graft from between the hair, the long hair. So there's once you can see right now the holes in between the hair, and this is for patient that requires less number of grafts. And in this patient, I did 1,300. It depends on the donor area, how many grafts we're gonna extract, if it's worth it to do it with long hair, or we tell the patients what we can do. So you can see here the tiny dots in between the hairs, but if we comb the hair like the normal style, then you can see where we extracted. So this is the way when we just finish. This is how the patient walks out of the clinic with the dry hair, that nothing happened, like nothing happened. So of course it's gonna be noticeable in the area that we transplant, but from the back, the patient, is not gonna wait until the hair grows back. So this is another option to give to the patient. So this patient was a great candidate for straight, but he didn't want it. So this is how the patient looks. Let me see. This is 4 days after the surgery. I was looking for the white neck. And this is how it looks 4 days after the surgery. I keep, again, as I said, the very next day with growth factors to close everything in a faster way. So if you are doing a surgery, if you're doing something in the scalp, or I think that growth factors helps to regenerate everything. So this is how it looks. So all the time, of course, we can have surgery with stem cells. This is some before and after. And so the question is that what the patient wants is a natural result. What the patient wants is to have more hair. So we need to give options to the patients to do. For example, this patient, gorgeous candidate for hair restoration, but this patient has some hairs in the middle, so also candidate for stem cells. Also candidate for stem cells and surgery. This is a patient for the video, and I want to show you this case. This case is a 38-year-old man that he came to us. Because he wanted to cover a scar that you can see in the photo in the middle after a motorcycle accident. So he wanted to cover. You can see the donor area looks very thin. You can see some of the scalp, the white area in between the hair. So he was not a very good candidate for hair transplant. A very large area to cover with a donor area that it was very thin. So I said, but this patient had some miniaturized hairs in the middle. So I said, okay, we can do a 2,000 hair grafts session and plus stem cells. So he agreed. So these are the result of the first hair transplant after a year. But what I want you to see is the donor area. This was the first time that I was so excited that I only applied the stem cells in the top part. I didn't touch the donor, but we know that the stem cells has a domino effect. this domino effect, meaning that we put the stem cells here and it migrates in the entire scalp. So you can see here how even the area that I didn't touch, this patient didn't dye the hair, which I thought at the beginning when I saw it for checkup. I was like, oh, nice, you dye your hair. He was like, no, I didn't dye my hair. And I was like, you didn't? I'm like, no, all my friends are asking me the same thing if I'm dyeing my hair, but no, my hair is growing darker. And I was like, great. So the hair was very thick. And even, I didn't do anything, but we did the stem cells. So you can see here how dark looks the hair. Here, look from the back. Even the lower area close to the neck in the occipital area, you can see how dark that hair, how thick that hair is. So, in the crown area, looks really good. So, and we did the stem cells. So this was 1 year after 2,000 grafts. So when I saw that a donor, let me show you so when I saw that, I was like, whoa. So then we decided to do. So this is the patient. So this was the before, and so we decided to do the first surgery, which was the 2,032 grafts, and so this is what you saw, the result after the first session. So when we have that donor area, I said, now you're a good candidate for hair restoration. So we decided to do a second FUE surgery. Now we transplant 4,500 grafts. So the patient now is crazy happy. This is after the first surgery, and this is after the second surgery. So you can see here how the before and after. This is 5 months, just 5 months ago, I did the second surgery. So of course, it's a huge improvement in the quality of this patient, quality of his life. He's crazy happy. So, and of course, he's keeping in-home treatment with, we did another session of stem cells in the second surgery. So what I'm doing is recommend to do it once a year to maintain the result. So then, because I'm a dermatologist, I also do laser. So all these patients has laser with stem cells. I inject the stem cells. I think they're so precious to just put it topical. I just want to make sure that I can leave it inside of the skin. And these patients are some before and after. This is fractional CO2 laser with stem cells. This is again laser and stem cells. This is laser and stem cells. You can see, the effect of the skin and how shiny the skin looks like, and the thickness when we touch it, and the healing process cuts. We can have a healing process faster than we used to see it before. So this is another patient, a little bit older. And with laser, filler in the here, and also stem cells. So there's not a single treatment that is gonna help us with everything, and we know that there's other applications of stem cells that we're learning at this, but I think that is promising, and I think that we need to keep us updated with all these therapies. This is our clinic that you're all invited, and we are just 5 minutes far from the border in Tijuana. So we have everything for to do that. So if you have any questions, I'm here. Thank you.
Just send me a little bio about him. Decided that he was going to send it to me in his native language. So not speaking Portuguese, I'm going to give it a shot. Dr. Herbert Lamblet cirurgião plástico do Rio de Janeiro, membro da SBCP, ASPSC, ISAPS, IFATS, and he's also the foco de pesquisa en gordura el células derivadas el gordura. I think he just made me say something really nasty. But Dr. Herbert Lamblet has been a wonderful friend of mine, and Habib's. I met him through Habib, and we've been doing a lot of lectures worldwide, and we've been traveling together. I got to really enjoy his company and his friendship. And one of the best things I could say about him, I think that what I just said in Portuguese was, he's the world's best Brazilian butt surgeon.
Thank you.
Dr. Herbert Lamblet.
Thank you very much. Thank you, everybody, for staying here. It's really a pleasure to be in Southern California, especially to see the kind of scientific meeting that we achieved, Habib. It's really an achievement to have all these people here and all the beautiful presentation that we saw. So back there in 2005, 2004, imagine we were just around the table trying to do something and trying to make something happen. So congratulations, you made it happen. It was wonderful, this meeting. Now I understand why Rajen did not put my name on the papers, because of the high standard of the presentations. So I sorry you guys. So I'm from Rio de Janeiro, Brazil. I live in Ipanema Beach, so you are always welcome there whenever you want. I'm going to talk about mechanical dissociation of the adipose-derived mesenchymal stem cells. I've been doing this for 11 years, more or less. I have no disclosure. So my history with fat grafting starts with my practice in plastic surgery like 20-some years ago. So this is like a picture of like 21 years ago. So liposuction and fat grafting was and still is the most common procedure in my practice. So since then, I leave the canister over the table during the whole process of the liposuction. At that time, I did that because I believe I could preserve better the fat cells. But something was in my mind that I could not just put this canister down there or not even throw some of the fat or the cells that I was collecting. So I was studying and brainstorming with this, and then I could realize that I was transferring not only fat cells, but other tissues and cells since 2000, more or less. So I studied more the fat cells. I saw the work paper of Howard Green and Grimald, and then I started to understand better what we were collecting. So from that, at that time, in 2000 more or less, we could understand that from the collected tissue, we have like two separate layers, the supranatant and the infranatant. But this is in 2000. So we could understand that the supranatant was basically mature adipocytes. The infranatant was the crystalloid that we used for the liposuction, and other cells, especially blood cells. The intermediate layer, you see that's a little bit more clean. You see that we could see that there were pre-adipocytes there. So when we were transferring those cells, we could understand that we were also transferring adipocytes, macrophage, blood vessels, endothelial cells, pre-adipocytes, vascular smooth cells, and fibroblasts. But when we say that now, it looks okay, because now we know that. But that time back there, we were really brainstorming on that. And doing that, we are getting good results. So we keep the flow, and then we study more, and we see the work papers of Juliana Ferrari and Gali, and then we enter in the universe of the regenerative cells. But in 2001 was probably the landmark in my practice, the studying issue. I saw the work paper of Dr. Zook and colleagues from UCLA. And at that time, in 2000, she identified a stem cell population within the adipose tissue stroma. So the same group, that's Dr. Zook, when me and Habib visited her at UCLA, we were together there. And then the same group not only identified those cells as mesenchymal stem cells, this in 2001, they identified that not only as adipose-derived mesenchymal stem cells, but also as multipotent stem cells, meaning that the cells from the lipoaspirate, play cells, has the same CD markers as the mesenchymal stem cells from the bone marrow, confirmed by flow cytometer analysis. So just one isolated cell from the lipoaspirate can derive 3 different tissue types: adipogenic, osteogenic, and chondrogenic. When this happens, you can call those cells adipose-derived stem cells. And then we know that mesenchymal comes from the bone marrow, the cord blood, and the adipose tissue. A lot of people talk a lot about this. So, following Dr. Zook protocol and with the help of Habib, we could develop a protocol for the chemical dissociation force. So what that mean? We published that later on. So we collect the fat at that time, 2002. We collect the fat, we wash with PBS, we add collagenase, and then we use an incubator shaker at 37 degrees for 30 minutes, and then we have like 2 separate layers, the infranatant and the supernatant. This infranatant is all this stromovascular fraction that everybody is now talking a lot. In 2002, we could make this. Habib brought all the equipment to Brazil and we could make this over there. So we were aspirating the infranatant, that is stromovascular fraction, centrifuging, and then we have a pellet consisting basically of all adipose-derived cells, including the red cells. So we use the red blood cell lysine buffer to buffer the cells, the red cells, centrifuge again, and use a cell stainer that's 100 nanometers. These cell stainers are going to retain cells and debris that are greater than 100 nanometers. So what goes down basically are adipose-derived cells, not adipose-derived stem cells, because for saying that these cells is adipose-derived stem cell, you have to go through a protocol, right? So we published that also again. And then in 2006, I was brainstorming. Because of the use of collagenase, we could not use those stem cells in the patient, like Dr. Berger explained it very well here. So I was brainstorming a way that I could use this and don't use the collagenase. So I came up with this idea, the mechanical dissociation force. So basically we were using a shear force to dissociate the stromal cells from the neighborhood cells. So when we do that, so we can, of course, this is part of the process. We are going to dissociate the cells from the adipose tissue stroma without the using of the collagenase. So we centrifuge again, and then we get the pellets, and then we go through the protocol again. We at that time, we were like using the trypan blue staining cell counting with the hemocytometer. This was here in California that we did at the Habib's place. And then we used the hemocytometer to count the cells. And what we could achieve in 2006 was like the mechanical could give you like 20 to 30 million adipose-derived stem cells compared to the chemical that was 30 to 40 million cells. So it's a good achievement by 100 mL of adipose tissue. So the interesting thing that we could achieve at that time also was that those cells are not only adipose stem cells, but they have like pre-adipocytes, endothelial cells, fibroblasts, and pericytes. But the interesting thing that 30 to 40% of those cells are mostly immunomodulatory cells, monocytes and macrophages, that gonna give immune response regulation to the composition also. So we were sorting those cells also by immunofluorescence and flow cytometry analysis. So they were CD45 negative, CD31 negative, and CD34 positive. When this happens, and then we can culture those cells in the lab, then we can call those cells adipose-derived stem cells. But there is a lack of research standardization to the bulk culture of adipose-derived stem cells in the stromal vascular fraction. Because when you are doing this at the lab, the ones that work in the lab knows that, you can use, you are thinking you are using a mesenchymal stem cell, but probably you are using a fibroblast. So until now, we have this lack of standardization in the lab. And also when we review papers, I'm doing review paper for some journals, we have like the standard characterization to at least say, okay, I'm using adipose-derived stem cells. So the cell has to be adherent to the plastic, has to induce indifferentiation culture to plast cells, and has to at least have 3 flow cytometry sorting for you to start talking that these cells are adipose-derived stem cells. Otherwise, you are just using like mononuclear cells population, hematopoietic or non-hematopoietic. And until now, we are in 2018, we don't have a CD marker specific for the mesenchymal stem cell. And the one that was for hematopoietic is the CD34 that everybody was thinking was the CD marker for the hematopoietic. Now is considered the CD marker for mesenchymal stem cells. So just to say that a lot of things is still moving in this field. So the adipose-derived stem cell is the prima donna, but we have to understand that within the stromal vascular the stromal tissue, we have also endothelial progenitor cells, growth factor producing cells, and the other progenitor cells. So when the beauty of this is then when separate those cells, that's what happened with the enzymatic. When you separate those cells, you're going to promote healing and repair through multiply mechanism because of the cytokines and because of the growth factors. So the new challenge would be growth factor producing cells, cytokines, interleukins, and exosomes that we just saw here, that beautiful presentations talking about that. And this is what we are going to hear more than stem cells itself. So the mechanical dissociation force is practical, close, minimal manipulation, preserve almost 100% of the adipose-derived cells, and released cytokines. It's collagenase and chemical-free, is safe, and has a shallow learning curve. So what we can do is like using this in combine, for example, now that we have on the shelf those cord blood, and then we can add this to our mechanical that is just bedside isolated. So, and this together with the scaffold that is the adipose tissue, we can do a great thing, right? So, like Dr. Berger said, if you are not 361, you enter in the 21 criteria of the FDA, and then if it's not minimum manipulated, and if it's not using other articles except of water, crystalloid, and any other sterilizing preserving, you are bad. You are in the 21 criteria, and then you all know what this happens. So, wait a minute, but this is not nanofat what you are doing? Not really. After a lot of brainstorming, the attorney recommendation was let him promote your technique, and then we show the paternity. So we are talking about bedside isolation within the operation room and chemical to mechanical dissociation force. Since 2006, with all the 2007, 8, 10, 11 we published, and then 2012, 13, and then we were doing, we did this project for the PhD at the University of São Paulo, showing the mechanical dissociation compared to the chemical. And this was very well described there, like this process. And showing the high standard of ethics of the Professor Masako Ferreira, that is our head professor there. When I first presented this paper in the university, she made everyone that was in the room to sign what they were seeing there. So at least we have like 21 witness at that time. So I'm not gonna bother you with results. This is just like all mechanical, but this is a full face fat grafting. Just some case, this is another full face. I think you are not really interested in that, but orbital, it's more for plastic surgeons. So this is orbital fat grafting. She made like 2 procedures before that was not done. Like skin disorders, you can improve a lot with the mechanical. Associated with the facelifting, this is pre, immediate post, 10 days and 6 months after procedure. Even like young males, you can do this procedure and then have like this kind of result. With the butt lifting, we do this a lot, even in elder patients. In Brazil, it's common that they love like doing this. So even like liposuction deformities, this is very useful. The butt lifting again, the primary case. A primary case of butt lifting also. This was a spinal cellular resection. She had like a scar tissue. This was in 2007. She has a scar tissue that she could barely open the mouth. So we injected like, that's during the procedure, 30 to 40 mLs of fat with the mechanical. And then after 2 years, she could open the mouth, and the defect was much better also. So peri-rhombic syndrome is very useful also. And that's Habib sent to me. There's like ulcers on the feet. And then combined with maxillofacial surgeries, it's very useful also. Like Dr. Collins said, here is very useful in that area. Sclerodermia. And this is a 2001 patient that we did the fat grafting, and then you could see that after 2 transplant of the fat, autologous fat transplant, the network of the vessels, there you cannot see very well. This patient had nothing muscle. It was the skin was glued to the bone. So we could make like 4 sessions, and then she had like 4 to 3 centimeters. So with this, we don't need flaps, anything. Just put a prosthesis, and the patient is happy after that. So spend some time on the lab is a key tool to understand fat and adipose-derived cells. So I thank again Habib and Dr. Zouk for introducing me to the lab work. So this is a very old picture, right? Right, Habib?
You were a lot younger.
Yeah, I look. Thank you very much.
You've hung in there for a long time. In a conversation, in long conversations I had with the late, great Nelson Mandela in the past, and I'd like to give you one of his quotations, is that everybody gets 24 hours in the day. How you use it is up to you. It seems like our speakers today have 28 to 30 hours in a day. And the next speaker is no exception, a complete slacker. He did medical school up in the Northeast at this place called Harvard, but we don't like to recognize that. Did a neurosurgery residency at Johns Hopkins and a fellowship in cerebrovascular surgery. He's currently a trauma neurosurgeon in Sacramento and the head of neurosurgery at University of California, Sacramento. Just for fun, he went and got a PhD in mathematics at Harvard University. Ladies and gentlemen, Dr. Tushar Goradia.
Okay, so I don't have exciting pictures, but I hope I can impart on you some knowledge of the spine and spinal disease today. I want to thank you for your kind introduction, and thank you, Habib and Rajen, for inviting me to speak. As a trauma and emergency neurosurgeon in Sacramento, I care for many patients who sustain irreversible neurological injuries. Patients in really bad car wrecks, patients who have sustained a stroke, patients who fall off a horse or have a diving accident that results in quadriplegia. It's because of my care of those patients that I am hopeful and see quite a bit of promise in regenerative medicine, and it's how I became interested in stem cell treatments. I do believe that to advance the field, we do have to move in baby steps. And today I'll be talking about not neurological injury, but degenerative disc disease that involves the spinal column. Degenerative disc disease is quite a bit of a burden to our society in terms of disability and in terms of healthcare dollars. So there is an important need to improve our care of these patients. It's probably responsible for about 50% of the prescription opioid epidemic. And to talk about degenerative disc disease, we have to talk about the intervertebral disc. Why am I getting that feedback?
We can't hear you in the back.
Okay. Maybe I should just... Okay. So the intervertebral disc is a fibrocartilaginous pad between adjacent vertebrae. There are 23 of these discs extending from the upper neck to the low back. And their main purpose is to provide flexibility of the spine. How many of you know people who have disc disease, spinal disc disease? So it is quite common. It will be affecting, if it hasn't already, some of us in the room. So it's important for us to learn about it and see what we can do to take care of it. Besides allowing for flexibility, the intervertebral disc is also a shock absorber. An analogy I use with my patients in clinic is that the disc is like the tire of a car. And imagine driving that car with low air pressure. What would that do to the rest of the suspension of the car, to the chassis, to the frame of the car, if you drove that car a long time with low tire pressure? So the pain people experience from this is often actually not the disc, but most people believe it's the disc. It's the rest of the car that's being damaged by driving with low air pressure. Okay? And when we speak of the intervertebral disc, we're speaking of a structure that has three subcomponents. It has the central gel-like nucleus pulposus. It has the surrounding fibrous annulus fibrosis, which kind of are like the the cords of a radial tire. Okay? And then top and bottom are the cartilaginous end plates that help secure that disc to the vertebra above and below. The challenge in treating degenerative disc disease, and this applies to other arthritic conditions as well, is that the disc is, the nucleus pulposus, that central gel-like part of the disc, is avascular. It doesn't have a direct blood supply. So when the cells in the middle of that nucleus pulposus need nutrition, they get nutrition and oxygen by diffusion through that cartilaginous end plate on the top and the bottom. So some of these cells can be as far as 8 millimeters away from the nearest blood supply. What this means is that the cells in the middle of the nucleus pulposus will often switch to anaerobic respiration for energy, and this leads to a buildup of acid in the central part of the disc and an acidic pH. So this disc itself in its center part is a hostile environment, and many cells can't survive in that environment unless they're specialized like the nucleus pulposus cells. From a biochemical point of view, the nucleus pulposus contains water and proteins, as well as these proteoglycans and predominantly aggrecan, which is a proteoglycan that tends to hold on to water. And this allows that nucleus pulposus to stay gel-like and hydrated. What happens when the disc starts to degenerate? Well, many people will not be symptomatic, but those who are symptomatic can experience back pain, difficulty walking from spinal stenosis as the surrounding tissues thicken, or if the nucleus pulposus herniates out, it can pinch a nerve and cause sciatica or leg pain. So here we see a comparison on gross pathology of a relatively normal nucleus pulposus and a nucleus pulposus that has aged and lost its protein and water content. And as this happens, that gel-like substance becomes more fibrocartilaginous and less functional as a shock absorber or as a flexible structure for the spine. This slide shows the various stages of degeneration, and most of us in this room have at least one disc that'll probably look like something in the third or fourth column. Okay, it's pretty inevitable for our discs to age. The aging disc results in a loss of disc height. So you'll see narrowing of the intervertebral disc as the disease progresses from left to right. You'll also get sclerosis, which is scarring, and calcification of those two end plates on the top and the bottom. And remember, the end plates are where the blood vessels come in. And as they become calcified and scarred, it's harder to get nutrition to the disc. So there are many things that are going on to cause degeneration, age-related degeneration of the disc. Now, surprisingly, the environment is only responsible for about 30% of your risk of getting this disease or symptomatically. 70% of your risk is genetic. So it is much more likely for you to develop this in a symptomatic, a clinically symptomatic way if you have a first-degree relative or a few of them who develop this condition. On MRI, we actually have a grading system. It's not used clinically as much as it is in research. But you'll see that as the disease progresses, this is a T2-weighted MRI image. You lose homogeneity of that nucleus pulposus, which is the white. I've got a pointer, which is the white here. Oh, I don't have a pointer. The nucleus pulposus becomes more heterogeneous. So here it's pretty homogeneously white. It starts to get some gray, and then as it progresses, you lose the white altogether, and you also have collapse of your disc space. Okay? L4-5, or lumbar 4-5, and lumbar 5 sacral 1 are the most common sites for us to degenerate our discs. At the molecular level, as discs degenerate, we're going to be losing some of that water-holding aggrecan and proteoglycans. So the disc does kind of desiccate as we get older. We also will lose some of those nucleus pulposus cells, the native cells within the nucleus pulposus that maintain that extracellular matrix that provide us with those good properties that a healthy nucleus pulposus has. So the nucleus pulposus, like most tissues, constantly undergoes anabolism, which is growth, and catabolism, which is breakdown. And the degenerative process reflects an imbalance of the two, where tissue breakdown exceeds tissue growth. And you'll see changes in the balance of important growth factors, such as TGF, or transforming growth factor, which is an anabolic factor for the extracellular matrix. And you may see, in these degenerating discs, you may see more of the MMPs, or the matrix metalloproteinases, which break down the extracellular matrix. Now, from the point of view of regenerative medicine, there are really only 3 types of discs that we need to focus on right now. There are those discs that have an early stage of degeneration, those with an intermediate, and those at an advanced stage of degeneration. The advanced degeneration, such as that seen in this lower picture, is too far gone for us to actually regenerate. There are too many structural changes to it. And that kind of a disc will probably not benefit from regenerative medicine. It will benefit, however, from technologies such as an artificial disc. And just in keeping with this theme of regenerative medicine, it is theoretically possible that a future artificial disc can be tissue engineered using regenerative medicine. It does not seem feasible in the short term, and there's quite a bit of artificial disc technology that is successful. So advanced degeneration is treated surgically for the most part, if it needs surgery, with disc replacement. The early stage of degeneration is actually probably nicely responsive to just biomolecular therapies, where you inject growth factors, for example, because they still have quite a bit of native nucleus pulposus cells that may respond to the growth factors. And it's just an issue of trying to change that balance of anabolism and catabolism in favor of anabolism. Where stem cell therapy applies is to this intermediate stage, where you've lost quite a bit of your nucleus pulposus cells. So you need to repopulate the nucleus pulposus with cells so that the cells can continue working on that extracellular matrix and create the important aggregans and proteoglycans to retain hydration. There are currently many clinical trials out there using stem cells to help regenerate the human intervertebral disc. And people have used, of course, the adipose-derived autologous cells, as well as cord blood-derived cells. There's a company called Mesoblast that is now in advanced phases of trials using commercial allogeneic cells to inject into the disc, and they've actually reported pretty good results. And I imagine that that will become FDA approved soon. So that is a reasonable option to actually directly inject the cells. But there is a problem with this therapy. When it applies to the intervertebral disc, there are actually a few problems. The first is, remember that hostile microenvironment? You've got an acidic pH, you don't have much blood supply coming to it, it's already a degenerating disc. When you inject stem cells into this disc, do you think they're actually going to stay alive in there? Who knows? But it's an issue of engraftment. Certainly less likely for them to survive in the hostile environment or the harsh environment of a degenerated disc than in other tissues. So that's one problem. The other problem is the needling. The moment you stick a needle into the disc, you initiate a degenerative process. In fact, the lab studies for degenerative disc disease with animals, the way they create the degeneration is they stick a needle into the disc, and that's their model for degenerative disc disease. So as far as the nucleus pulposus is concerned, present stem cell technology is not the ideal solution. So what is the alternative? Exosomes. Have we had the exosome talk today? I arrived late. We were supposed to. Did...
mentioned it several times.
Okay.
We're not really.
Okay, so let's talk about them. So exosomes are these nanoparticles that are released from the cell, and they seem to have quite a bit of the biological activity, and maybe even a lot of the biological activity from stem cell therapies. So in general, there are three types of broad categories of extracellular vesicles that the cell will emit. They're going to be the microvesicles and the apoptotic bodies, and those don't have as much biological function. But then there are these nanovesicles, and they carry specific cargo. They can carry growth factors, lipids, and microRNA and other types of RNA. But a limited combination of these factors, and they're used for cell signaling. So cells actually communicate with each other by one of them releasing an exosome, another one receiving it. And then the receiving cell will respond to whatever is in the contents of that exosome. The reason that this seems promising, again, many reasons actually. First is exosomes are not cellular. They don't have a nucleus. They are simply packages of important growth factors, mRNA and so on, or microRNA, that may and probably do have biological function at a remote site. Okay? So they don't have the metabolic requirement of a cell. If you inject exosomes into a disc, the exosomes won't demand nutrition like stem cells will. The other thing is that these are nano-sized. These are, does anyone know how big an atom is, the diameter of an atom? Let's use a hydrogen or helium atom. Of course, I know because I prepared the talk. So. Okay. So the exosomes range in size from 30 to 200 nanometers. But of course, there are many beyond those extremes. An atom, a helium atom, has a diameter of about 0.2 nanometers. So exosomes are only, at the smallest exosomes, only about 400 times the size of an atom. This is nanomedicine. This is about as small as you can get. Because remember, after you get, beyond exosomes, you're talking about molecules. And those are the, biological molecular therapies. So because they're nano-sized, you can inject them with the finest of needles. If you use stem cells in your practice right now, you have to use the bigger needles to avoid damage to your stem cells as you inject them. These, in theory, can be delivered through very small conduits. Then the other really nice feature of exosomes is that they have a bilayer membrane. Not just one lipid membrane, but two. So they can actually resist a harsh environment better than cells can, in theory, because of that. They can resist degradation. They can maintain persistence in a location, perhaps even longer than stem cells. So they can theoretically there can be a repository of the exosomes. When you inject them, only those that are needed at the time will be taken up, and there's still some more left, and then the native cells will continue to use those exosomes as needed. So these are really nice. This is a really nice tool for regenerative medicine, the use of exosomes. So as it pertains to degenerative disc disease, this is a paper that came out last year by a group in China. It was really nicely done in terms of science, and it illustrates a lot of the ideas behind exosomal therapy for regenerative medicine. Again, as it pertains to degenerative disc disease and the nucleus pulposus. What they did was they took the discs that were removed surgically, so 10 patients had surgery to treat herniated disc disease. The researchers took the discs that were removed and isolated the nucleus pulposus, and then isolated nucleus pulposus cells, and then cultured those cells. They also took mesenchymal bone marrow cells that were commercially available, so these are from unrelated patients. And they were studying the communication between the nucleus pulposus cells and the mesenchymal bone marrow cells. So there are these two populations. And they're looking at the exosomes that are being released from one to the other. Okay? So this is actually a transmission electron microscope photograph of exosomes. On the right panel is a control, on my right, your left. But these circular bodies are exosomes. So these were actually visualized by the researchers. Again, the exosomes in this study was about, they range in size from 30 to 100 nanometers. And obviously an appropriate stain was used to help reveal these to us. This is a neat photograph. It actually shows exosomes. Remember, I said there are two populations, the nucleus pulposus cells from patients, and then the commercially available mesenchymal stem cells. This is showing those little green dots you see on the left when they're merged with the other staining of the cells. You can actually see uptake of the exosomes from one group of cells to the other. So on the top panel, you have bone marrow mesenchymal cells that are ingesting or have ingested the exosomes from the nucleus pulposus. And on the lower panel, you see vice versa. So you have nucleus pulposus cells that have ingested the exosomes from the bone marrow mesenchymal cells. All that needed to be done is if you have a population of nucleus pulposus cells, they added the exosomes from bone marrow mesenchymal stem cells, and then waited a while, and then saw the uptake. So there are many features of the exosomes that they studied in this article. One is the chemotaxis that the exosomes induce. The more exosomes that were present, and in this case they used the nucleus pulposus exosomes to help stimulate migration of the bone marrow mesenchymal stem cells. As you increase the concentration of the exosomes, you're getting more migration. What does this mean in theory? It means that in theory, if you inject the nucleus pulposus exosomes into a disc, you may be able to recruit native mesenchymal stem cells into the disc. Here they're looking at the protein that the nucleus pulposus exosomes cause the bone marrow mesenchymal stem cells to express. And these are actually proteins of the nucleus pulposus. These are proteins that the nucleus pulposus cells would normally make. By adding exosomes from nucleus pulposus to unrelated bone marrow mesenchymal stem cells, you're getting expression of nucleus pulposus cell proteins in those bone marrow cells. And then if you look at the exosomes themselves to see what the cargo is, here we see that the nucleus pulposus cell exosomes are actually expressing a transforming growth factor, which is an anabolic growth factor, transforming growth factor beta. That's not as important. And then finally, let's look at the proliferation. If you inject the bone marrow mesenchymal stem cells, in theory, you can cause nucleus pulposus cells to proliferate or replicate. So these exosomes, at least in vitro, are demonstrating many important biological features that are useful for regenerative medicine. Indeed, in the talks you've heard earlier, it may very well be that it's the exosomes that are doing the magic. Okay? And exosomes are everywhere. They are even in our urine. They are secreted. So we may be thinking that it's the stem cell. Even when you inject the amniotic fluid or the cord blood, we may think it's the stem cells that are doing the magic. But I think it's very likely that it's exosomes. When we talk about growth factors, it's not necessarily true that these growth factors are just bare in your fluid. They may be encapsulated in exosomes, and then it's the ingestion of the exosomes by the native cells that causes the changes that you see. So I believe that the evolution of this field will involve more attention directed towards exosomes. And remember, exosomes have a limited content. They can, in theory, be mass-produced. And they can also be designed to carry particular drugs even. So there are ways to take these exosomes and then put little drugs or other molecules into them and make them do some type of therapeutic magic. Thank you. Question?
Where are you getting your exosomes?
Where would I get them? I have them in my saliva. You want some?
I need to mass produce them so I can inject them, I guess. But
Okay, so you would do a process of centrifugation and filtering. I mean, that process is well known now. That's what they did in the study. I'm sure Habib is aware of that process. Remember, they're nanoparticles, so they can be separated from other cells by using nanofilters. Okay? And then you can identify their protein content and do all kinds of things to try to separate them out depending on the microRNA they contain, the proteins, and other growth factors.
are you looking for different types of exosomes depending upon what area of the body you plan to inject?
Oh, depending on what disease you even. Remember, these are signals in part. Okay, you can use them in theory, and people are doing research on this for treating cancer, to prevent cancer cells from inducing angiogenesis. Like, so one exosome that's been identified is a cancer cell when it's in a hypoxic environment, because cancer cells grow quickly. They outgrow their blood supply. So then it becomes hypoxic. And then the cancer cell will send out little exosomes that will induce angiogenesis. Okay? So there's a wealth of ideas out there when you start thinking about the exosomes. And you're becoming more targeted and more scientific. Rather than just throwing stem cells at everything, you're actually now doing this in a thoughtful way, and you can start to model the biological systems and start to analyze them, and then create appropriate therapies. Mm-hmm.
Based on that theory,
Yeah.
and this is, I'm sure that almost everybody in the room who's done clinical work has been asked this question. Are you specific about the site in which you will inject the exosomes? For example, low back pain, disc disease. Do you inject directly into the disc? Will you inject paradiscal, parafacet joint, into paravertebral muscles? You know what I'm getting at.
Yeah, and actually this is another really nice feature of exosomes. They are nanoparticles. Right? So they don't cause the embolism that was mentioned earlier. Up until now, we have not been able to identify a good treatment for brain tumors because many chemicals and cells cannot pass the blood-brain barrier. Okay, the blood-brain barrier is there to protect the nervous tissue from receiving unnecessary or foreign substances. Exosomes can pass the blood-brain barrier. So you now have a delivery vehicle, theoretically, of getting into the brain just through IV injection. Okay, so if you do have these designer, for example, exosomes, and you inject them into the bloodstream, they may be taken up by the disc area, the blood vessels of the disc or near the disc. So it may be that you don't have to even do direct injection.
So a blind paravertebral muscle injection will be as effective as a targeted specific injection into disc?
Yeah, I think paravertebral is a little too far away. So I mean, either you're going to inject it into the disc, or you might as well just inject it somewhere and then see if it, let the bloodstream deliver it. But I don't think that there's going to be like a local transmission of the exosome from a paravertebral location to the disc. I don't know. There's a lot we don't know about exosomes.
Yeah, but it's paraphernalia, right? So it should be around the tissue area. It's not visible very far.
Yes.
Is the only way to elicit exosomes is by injection immediate topical?
In theory, yes. Again, remember, this is not this is research, and I'm not an expert. I'm just a brain surgeon. But
Can I ask the other speakers to come up?
The fluids,
yeah.
They have right to inject with the fluid, like spinal injection.
Yeah, so exosomes can be used, for example, in theory, to treat spinal cord injury. If you inject it, then, but part of this also depends on a willing receiving cell. So you can have the exosomes floating around, but for them to have a strong biological effect, you need cells that will actually ingest them. Yes?
Can you please share your thoughts on treatments on medical blood cord and stroke? There are a group of neurologists that are injecting it intrathecally or using the ventricle.
Yeah, I am of the mindset that it's nice to see the results. Ultimately, I'd like to know how it's happening. I know I'm not as optimistic about stroke treatment with umbilical cells, but I've heard a lot of positive results for autism, for example. And there are mothers who swear by this for their children. In fact, people will go to Mexico to have the treatment done for their children. From what I've heard, it can work for months, and then it'll wear off, and they need another treatment, and we don't know why. So there's a lot of opportunity for us to learn about this technology, why it's doing what it's doing. Even the previous speakers revealed amazing results with stem cell injections, and we still don't really know why. We have theories, but these theories have not been proven scientifically.
While we're getting our podium set up here for the rest of the speakers to come up, any more? I'm happy we have an entire hour, I think, or at least 45 minutes for questions. I know you've had a lot. You've been very patient. So with the rest of the panels coming up, please, anyone has any questions from the entire day? So your hands back there in the back.
The mannitol to help that transport across the barrier.
Okay, so your question is, because exosomes can pass the blood-brain barrier, how does that relate to mannitol? Okay, mannitol, is used to treat intracranial hypertension. So it's already an effective drug. What are you specifically trying to do? To do what?
Stem cells or exosomes. You had mentioned they have difficulty passing the blood-brain barrier. Doesn't mannitol help open that up?
Well, you don't need it. Again, exosomes can pass the blood-brain barrier. There's no problem with that. They'd have to be of the right size. I don't know what the size is.
I'm going to speak to that for a second. If the panel can come on up, please, and take a seat. I think what you're referring to, there's a myth that's been going around for several years now, that stem cells or stem cell products or exosomes can be accelerated to cross the blood-brain barrier by the use of mannitol. Well, I've been a trauma surgeon for over 25 years, and so is Dr. Goradia. The only time I've ever used mannitol in practice of medicine is when somebody had intracranial hypertension or somebody had a bleed and we had to reduce the pressure. So it is a sugar. It is a diuretic, an osmotic diuretic. What it does is by osmosis, reducing the fluid from one area to the other, in this case from in the intracranial environment into the intravascular environment. There is no indication that in the process of doing that there's co-transport of something else into the brain. So there's nothing to say that the stem cells will be accelerated across the blood-brain barrier into the brain with the use of mannitol. It's unfortunately a myth that's been perpetuated in certain clinical environments, and let me be the first one to disabuse you of that concept. I personally, as a physician, will not support.
Okay, my experience with stem cells is mainly with androgenetic alopecia. The kids that I have, it's with alopecia areata are kids, so we're not inject those kids, not IV, not the scalp. So what I'm doing is with kids, I'm using the topical, like the Reluma, with growth factors, in combination with the gold standard, which are the corticoids, and I combine it in the morning, the Reluma with the clobetasol, and at night too. So that with kids that I have with alopecia areata. Now with patients with androgenetic alopecia that I'm doing the stem cell therapy, I inject always the stem cells and intradermal stem cells applications. It's always in injections. There are some doctors that they want to do a roller or they want to do other kind of a topical preparations. I think that the stem cells, where we want them to work, we want them to work at the roots. And the roots are in the dermis, going in between dermis, deep dermis, and the fat tissue. So you want the stem cells to work there to stimulate the roots and then to regrow the hair. So that's why I always inject the stem cells. I put the NAMI anesthesia cream, and then I put the rim block around the area that I'm gonna work with, and then I inject it.
Yeah, when you say stem cell, what are the stem cells? What are the source? What are the stem cells?
Cord blood stem cells from Invitrx.
So for the autoimmune condition like alopecia totalis,
It is a place, we don't know. In this case, these articles, the application was IV. But I didn't explore that because the kids that I have, they're kids, so, yeah. Yes.
So the stem cells you purchase from Invitrx, what type of stem cells?
It's cord blood stem cells, and we give to the patient the two options: the cord blood stem cells and the fatty autologous stem cells. Yes, and the patient decided. And I have very thin patients that there's no fat to do the liposuction. That I'm working with a plastic surgeon. I'm not doing it. It's a teamwork, and then the Invitrx teams. Comes to the clinic and then we do that. But the patient can choose but both stem cells are from Invitrx. Thank you.
Another one, I have another question was that what was you showed an article where that lady who had complete baldness and in 2 years. What was the stem cell? What was the source?
No, they don't say. They just said stem cells. Yeah.
You have a question?
Do you apply the growth factors first, the topical, or do you inject it with the stem cells?
No. The Reluma products is a topical preparation that comes in two forms. In form of a shampoo, so I leave that in the prescription to the patient. They're gonna wash the hair, and they're gonna leave the shampoo for 5 minutes, and then they're gonna rinse it off. And then the topical preparation is a lotion. Also is Reluma solution, and that is a topical preparation, so you can leave it once or two times a day. But it's topical, so it's a lotion. But it's not greasy, so you can use it in the morning or at night. Yes.
So this question is directed both to Dr. Salas and Dr. Naidoo. The Reluma, if I'm not mistaken, that's a dermal fibroblast-derived exosome, right? Isn't that part of the product itself?
That's my understanding. It's a broth from the dermal fibroblasts.
Broth or conditioned media. Broth is a little too rogue for our terminology, but that's okay.
So you're using topically then a dermal fibroblast-derived excretion topically, and then injecting what volume is to cover the entire 6 cc?
No, 2 cc's. Yes, you just apply like 10 million stem cells. So you apply like a very tiny amount of that, and you distribute in the entire scalp. And I cover always with 2 cc's from the frontal hairline to the crown, and not to the rest of the scalp. Then we will need more. But what we notice is that when we cover the top part, then by a domino effect, you have response also in the donor area.
Dr. Salas, you mentioned earlier that you use clobetasol as well.
For what happened is in alopecia areata, the gold standard is to apply clobetasol, a high potent corticoid, twice a day. So we're not going against what is already proved, but we add in the benefit of the growth factors to the gold standard treatment to help the hair to, once the inflammation settle, then the growth factor help the hair to regrow in a faster way. So that's where we're seeing that when we start working that way, the hair, especially when we have small patches, we know that normally we can see the results of the corticoid therapy, like in a month we're gonna have like 20%, 10%, but when we add the growth factors, we can see double the effect. So we know already that in a month we expect this certain response in 2 months, in 3 months, and we give to the patient like a certain percentage of what we expect every month. So when I started to add that to my therapy, it responds really fast.
Topical anesthetic when you're doing the implants and the stem cell injections.
Yeah, I use. If we're doing hair transplant, no topical, because I put rim block.
So you just do a rim block?
Yeah.
The Dr. Goradia explained that there's a pretty toxic environment in the cells because of the lower pH. The topical anesthetics have a lower pH. Do you find there's any detrimental effect to these stem cells?
No. Actually, I will go back and check. There's an article that says that the stem cells actually reactivate under a hostile environment. There's an article that they saw that during periods of hypoxia, the stem cells reactivated. So I'm gonna go and I read it like 5 years ago, but when I heard that, I was like, let me check again that article that proves that in the skin, And I mean, he's talking in more in-depth tissues like the disc and that. But in the skin, what they saw, it was in ulcers. It was an article that they talk about ulcers, that there are a lot of necrotic tissue. So they put the stem cells and how they can help those very hard to close ulcers and to put the stem cells and they close, and Habib had a lot of experience in that area. But it's an environment that it's necrotic tissue with no oxygen, and that in terms of hypoxia.
There are a lot of studies done in actually to see even cancer cells, the lactic acid, the acidic, because of anaerobic, oxidation. Actually, it's, fast-growing cells do have, like skin cells, but like hair follicle cells, do generate, a lot of lactic acid and very acidic. And actually it's very good. Lactic acid, for example, what you're saying is true. Actually, it helps. The conventional theory was acidic is not good, but it helps to regenerate. It helps to, to heal wounds, not the other way about.
I think it depends. I think it depends on the tissue that we're talking, and I'm talking. Yes, I'm talking in terms of what I know about the scalp and that. And I remember that article that they proved that under those hostile circumstances of hypoxia, yes, the stem cells helps like with those kind of situations. So I don't know the disc and that. I don't know anything about that area, but yes, of course.
I think one of the benefits of the hostile environment is the differentiation pathway. So when you have a hostile environment, the stem cells will tend to differentiate towards cells that will survive that environment.
No, but now, for example, the theory was before in cancer, for example, at the core of the tissue, what you're saying is very hypoxic. So people got the hypoxia. Right, so therefore, it's, they have to grow because very hostile, even cancer, for example, or rapidly growing cells like hair follicle cells or skin cells. But it's not true, right? Now there are a lot of studies to suggest that it's not true, right? That the acidic environment is not negative; it actually is positive. So I don't know.
Yeah, for cancer, it's positive because it will induce the cancer cells to create angiogenesis factors. But you're saying in terms of proliferation, it may help proliferation. I don't know that.
Yeah. I would like to ask to the table, following the window that Dr. Salas just opened, the experience of each one. If you use any kind of immunomodulation in your experience, can be in vivo or in vitro, to try to modulate the immune system, and then maybe go even further, like with the suppression of the immune system. So if you are using any kind of immune suppression, like the corticoid that you are using, and you get good results with that. So that's an important issue right now, right? So I would like to see each one perspective on that.
One of the ways that VEGF syncs work, and one of the ways that VEGF antibodies work, like Avastin, bevacizumab, is they reverse the angiogenesis process within cancers. Now, people think that anti-angiogenesis drugs kill the blood vessels that the cancers are trying to use to grow. They don't. They change the anatomy of the blood vessels. So the blood vessels in cancers are very the blood vessels in cancers have a lot of large pores, and they're very sinuous, so that cancers actually have a higher blood flow compared to the normal tissue around them. That's what VEGFs do. They don't stimulate. They stimulate pressure of the blood vessels, but the biggest effect they have is that they effect they have is that they change the blood vessels to more normal appearing highways instead of tortuous little blocks. And so you decrease the capillary flow to the tumors, and the tumors, basically, the environments, they become more acidotic, and they don't get the same access to oxygen and nutrients. And now you've starved the cancer that's growing fast. The cancers need that extra oxygen and extra glucose, extra nutrients to grow. When you give Avastin, or you give bevacizumab, or aflibercept, which is an actual sink, and they're now antibodies against the actual VEGF receptors, you change the anatomy of the blood vessels, so instead of the blood vessels not having higher flow rate into the tumor, it's back to normal. And now the cell that can't grow as fast. That's how these drugs work. So you were asking before about angiogenesis. That's how they work. It's the cancer cells have an advantage to growth because the capillaries become more tortuous, increase surface area, and have bigger holes, so they can get through more volume of plasma into the actual interstitial tissues.
Yeah, but let's be very specific. So do you believe that immunomodulation or chemotherapy has to play a role in when you are like using any kind of stem cell treatment?
Absolutely, absolutely. Clearly, I demonstrated this morning on the slides that I showed that when you have anything that interferes with the T cell PD receptors and the TIM and LAG receptors and the CTLA4 receptors, that definitely that's the cancer cell using its immune inhibitory resources to stop it from being attacked by T cells. So we have therapies already that I showed you today, the checkpoint inhibitors that are very effective. But there's so many other things playing a role. For example, you've got checkpoint inhibitors blocking the immune inhibition effect of cancer, but then you have the cancer cell secreting other drugs that are suppressing the T cell like TGF-beta, specific TGF-betas, not there's like 45 different TGF-betas. So yeah, it's more complicated than just the PDL or PD-L1 ligands or CTLA4 ligands. It's very complicated. There's several factors going on. Myeloid myeloid-derived suppressor T cells, Tregs are secreting small molecules, probably and exosomes in the form of exosomes to stop the cytotoxic T cells from being activated and put them into an exhausted state. So that's where the next level is. How do we figure out, number one, how to stop that from happening? Number two, how to make the T cells more specific so that they will only be activated in the presence of a tumor environment. I didn't mention this earlier, but there's now new technologies where you can generate antibodies with masks. And the mask is cleaved off in the presence of pancrease. And pancrease is in high levels of concentration in tumor environments. So you can create antibodies that will only get weaponized when they're circulating in a tumor environment. The mask falls off, now the antibody can then attack, right? Well, nobody has yet done this, but it'd be nice to see if they come up with a CAR T cell that has a mask on the effector site. So when that CAR T cell is circulating in the tumor, the proteases take the mask off, and then now it becomes active in that tumor environment. So those are all things that have to happen, we have to see happen in the next 10 years, I hope.
There are also some studies showing or proposing to use the stem cells in this graft against donors disease. For this reason, it's specific to modulate the immune reaction. So many studies are showing that you can add the cells to make this modulation. Definitely they have a role.
So, since I'm the exosome guy right now, I'll say that exosomes don't have much on the membrane. At least you can use exosomes that are not antigenic, in theory, and therefore would not need any immunomodulation.
Okay, but you said, for example, that you are injecting stem cell and then you are producing a scar tissue in the area that you are injecting the stem cell. If you use an immunosuppressor before, I'm not saying
kind of an immune suppressor, let's say corticoid, for example, these would not solve your problem?
No, because it's not just the scar tissue. Remember, the degenerative process is causing its own scar tissue all the time. Right? That's why you degenerate the part. You're also depressurizing that nucleus pulposus. You're allowing fluids to leak out. You now have a hole in your tire. That's slowly. So, and obviously, if anything, the immune system may help seal the leak. So it's not here that you need immunomodulation.
Just want to say something about the research.
All of them do?
Exosomes
Yeah.
recapitulate the structure of the component composition of the membrane of the campo. So the campo macrophages or lymphocytes.
Yeah, and all I said is you can probably create the exosomes that are not antigenic as depending on how you manufacture them.
I would like to hear
We just had Habib as last question.
Dr. Raja, a quick question for you. From a therapeutic standpoint, do you feel that using a specific exosome to treat the same tissue? There was a talk in San Diego that using exosome from culture of the myosine is preferred in the body tissue.
So you need to understand that exosomes are coming in many shapes and forms. They have different sizes, different colors. And so probably better to use exosomes, for instance, for the same tissue if you want, if that's what you want to do. If you want to regenerate or give something with tissue that doesn't have it originally, there's no point to take the exosome from the skin. If you want to give because basically what we need to do is identify who the owners, do all the analysis, to see what the exosome has. Because we need to understand that not only the exosome of certain tissue has something, but it depends on the state of the tissue. If the tissue is injured, we will have another type of cargo in there. So I think this is not a very clear cut. I think we need to understand what we want to deliver by the exosome. What is the endogenous cargo that we want to deliver? And this is how we do. Many times it will be the MSC derived because they are beneficial cargo to the individual. But I think we need to understand better what exosomes are, what type of exosomes. There are many types. And we need to determine based on what we are missing. What is our goal? What do we want to achieve?
Well, just in your clinical experience, any kind of immune modulation or not?
For MSC?
No, for exosomes or MSC.
So again, it depends. Exosome derived from MSC is very low level because MSC. So for MSC, but if you take exosome from macrophages or the Dutch cell, we have to consider that the rate of
I think when I brought that up earlier, the extrapolation of my simple Hebert version, I think very simple. I was aiming at trying to understand if I am affecting the stem cells if I'm injecting cortisone into the joint of the stem cells.
So this is being done few times. And again, it depends on what you want to get in yourself. So this is the question. What do you want to get? Because steroids will not do major changes to them, to some results, but with other, yes, they will change the cytokines. So really, the question is what do you want to get? You know, you want to get regeneration, fibrosis, inflammation, what do you want to get?
I think that the data has shown over the years that it's very difficult to read, for example, in an osteoarthritic knee environment. We are not regrowing, we are not regenerating and stimulating osteocytes. We are not regrowing type 1 islet cartilage. At best, what we can do is grow type 2 fibrocartilage. But the latest Japanese, I think in June 2018, the Japanese literature showed that the exosomes were responsible for slowing the rate of degenerative change, the rate of cartilage delamination. So the question, from a clinical perspective, if comes in and you dismantle it. If somebody comes in and says, I've got a lot of knee pain, I can say, I'll give you stem cells, it'll take you a couple of months to reload, but let me give you some immediate improvement with cortisone, which may happen in 48 hours, and it's mixed generally with local anesthetic, which is lidocaine, which is a more steady practice. My experience over the last 8 years of clinically using it is that it does not influence, does not have a negative effect.
But again, you need people question and see what you
Yeah, what's that? Let me just give you a chance to
What we're doing right now is a shotgun approach. We don't know how our therapies are working, the actual mechanism. This is a wonderful area for exploration and research. So the question you're asking really depends, the answer depends on additional research. Right now, we're just throwing in growth factors all the time. We know that the umbilical porous blood is natively there to help promote growth and tissue growth. So that's why it probably has some effect. But when we get specific to spinal cord injury or stroke, there may be very targeted therapies that we will understand as research continues. Well, maybe, but it's still pretty limited. Again, if you use the tire analogy, there probably is a size of something that you can puncture a tire and it won't harm people. And that has to be determined. I don't think it's going to be in the range of the 20s. I think you're going to get into the 30s for the gauge in order to be less dramatic. Harder to play. Right, so usually you see what you might need is a docking system and additional technology.
Well, if you're getting so deep into the tissue, you need at least a 6+ inch length to get down there, right? Maybe even longer trocar. And as you get into a 30 gauge plus needle, you're not going to have that stiffness to direct that needle.
Yeah, you're not going to stiffness, but you will also be able to get between fibers. So you may not actually be doing dramatic injection. You may be separating fibers. You may be finding a pathway to get it. So that if you get a stylet in there, that might help. But yes, that's technology that has to be developed if it's not already.
But even Pascal told us that smaller diameter needles can have a lot of pressure to get the volume of fluid into. So is that going to cause a lot of trauma inside of the needle nerve? We have in a pretty bad way.
Well, the pressure is in the needle. Once it's outside, there's not going to be pressure. So you wouldn't affect the nerve. The nerve is protected. But again, it could be, as we learn, and maybe 5 years we'll know this, that exosomes do travel hematogenously to the desired site. It may be that we don't have to inject directly at the target, but well, remember, it's poorly vascular. The nucleus pulposus is poorly vascular, but the end plates are vascular, and there are resident stem cells there. So you may create a process by injecting exosomes and stimulating those stem cells, and they may do what they need to do. They may generate additional exosomes. I'm just giving you, one scenario. There's so much we don't know about them that it's just exciting to learn about it and to do the experiments.
Since they brought up the question,
yeah,
do you have epidural injections of stem cells?
No, I don't think they're targeted enough. I think we've seen problems with epidural stem cell injections, but the autism children are getting them epidurally, and they're doing well. It's just that there is a complication rate because the immune system may create scar tissue and can even create a mass in the spinal canal. I just don't like the idea because it's too blinded an approach without understanding what you're really doing. But then again, when you're desperate, when you give a child with autism and you know it has worked for that child because you've tried all kinds of things and this is the only thing that's worked, then I think it's very reasonable to do it because it can be life-changing.
Yes. I have a follow-up for Dr. Salas. In your field, have you seen a difference between jelly or blood stem cells or exosomes with hair restoration? Is there any benefit to add,
Okay, I'm only using, my experience is only with cord blood stem cells or from the autologous stem cells. And I do have cases that I combine the PRP with stem cells. And I think that the stem cells produce its own growth factors. The platelets produce their growth factors. So I think that when you have a lot of miniaturization, when you really want to add everything, it's not harmful to do it. It's their own patients' growth factors. So from if you're using PRP, I'm not using anything else besides that. And it's the company that I work with, it's Invitrx, that I trust, that they're, because that's another thing. There's a lot of ethical ways of doing it, non-ethical ways of doing it, and there's ways, these are cells that the company needs to run all the tests and all the different things because those are not your stem cells. These are coming from other patients. So the company needs to have all the regulations, and you need to see, actually my first visit before ordering anything was to Habib's office, and he walked me through the entire process, and I was in the office, so I spent that day just learning about that, got my attention in one of the congresses, and then I decided to work with them. But I mean, first not to harm. So it's my duty to work with the company that I know that they're gonna follow the ethical standards. They're gonna have everything in the regulations and everything to feel good about offering this therapy to my patients. That at the end of the day is my face in front of the patient. So that's why I'm only working with those two stem cells.
Question in the back.
Dr. Salas, any role for stem cells in wrinkle treatment or role in acne, severe acne?
Yes.
Right.
Yes. Right now we're starting something with acne scars, post inflammatory acne, and it works phenomenal. So next year I'm gonna bring those cases, but there's not a single treatment actually for scars. There's not trophic scars. There's not a single treatment that is gonna give us a tremendous result. So we need to combine therapies. So I combine the stem cell therapy with fractional CO2 laser, that we know that the laser can help us, but it's not it is not enough. So I add the stem cells directly into the center of the scar, and then you can add more benefit to that with combination of the two therapies. And in terms of the wrinkles, yes, that's why I'm doing it in combination. When the patient, I offer it to the patient just the CO2, fractional CO2 laser, and I tell them what I expect to have and what we can achieve if we add stem cells to the therapy. And of course, the man, the 83-year-old man, was my father. So he was just finishing chemotherapy, and he lost like half of his weight, and he really wanted a facelift, but he couldn't. Oh, he was in chemo. He was still in chemo, and he really wanted like to have something for the face because of the loose skin that he didn't have. So he was like a little bit depressed about that, and I said, well, you can have facelift right now. So then we decided to do laser and stem cells, and so he was crazy happy with the result. So he decided right now, thank God he's a survivor of cancer of more than a year, and the idea of having a facelift is not on the table anymore. So I think that is a perfect combination. You want to put the stem cell where you want to, what you want to do. You want to improve the layers of the skin, then you're gonna inject it where you want it to act. You want it to act in the scalp, inject it into the scalp. So that's why when they want to do it, like to improve the ejection fraction in the heart, they put it central catheter directly into the heart. So you want to direct the cells where you want it to act, so more directly. So yes, of course, there's a place for rejuvenation. That's why I'm so excited to have my therapy, because my face is gonna be more younger look after you're gonna do my therapy. I'm excited, and so yes, there's a place of stem cells. There's a lot of roles of the stem cells in all the areas in the body.
Xerxez?
Yes, please. Dr. Salas, I agree with you that the closer you get to the structure, the better. But these cells are pretty smart. You get it pretty close to where you need to be, and the effect is really fantastic. I have quite a few patients that, for dental indications, we've seen the scarring disappear around the mouth area, the nose, and also the disappearance of the wrinkles, and especially around the mouth, around the laugh lines and the marionette lines, and the crow's feet, and right here. And I don't even come close to those areas. I just keep it into the buccal fold, and it just goes. Most of the straightening and smoothing effects of the skin really happens really mostly on the cheek areas here, and that's the most significant that the patients report back. They go, they'll usually get a comment like, "Did you get Botox?" And said, "Goes, no." And the patient's family and friends will just say, like, "You look fantastic. You look really, really good." And that was a side benefit of what we were doing for them for a dental indication. But as far as getting it close, if you have the ability to go ahead and do that, absolutely. But you don't have to. You just get it into the same area, and it's kind of a grenade effect.
Yeah, and you're a round face, so that's why I'm so excited.
The stem cells, when either infused or injected, is there something that induces them to produce, to manufacture the appropriate exosomes, cytokines in a particular area? The preface for this question is that I use a lot of stem cells in my immediate post-operative period. So if I'm doing a rotator cuff massive shoulder repair, I will inject stem cells immediately. Is there something in the trauma that is created in the tissue by needling, by injecting, by doing some work that will induce your endogenous inflammatory response that will trigger the stem cells to work, versus if you are going to infuse stem cells into a healthy human being, are they going to remain dormant? Questions. So let's start from one end. Doc, you had a lot of experience there.
No, I don't have that much experience, Rajen, so I really don't know. all I know is that the stem cells contain the exosomes, and whether they produce more because of the injury, I don't know. The researchers probably will know.
Yeah, that was my question in the beginning. So I believe that when you have any kind of immune modulation in the body, especially, you see, she said, Dr. Salas said, oh, I did corticoid, it works better. Then my father had the chemotherapy and then works better for him. So any kind of immune modulation that you produce to the patient, especially when you have a surgery, the patient, the renal patient, they are immune competent. So they compromise. So they have some kind of immune modulation that makes the stem cell to work better. There is something coming right now saying that corticoid and low doses of antibiotic, even antibiotics that were not used anymore, they can produce some kind of immune modulation, and they can regulate better the action of the stem cells, of the so-called stem cells, because as we saw, it can be other things, like even exosomes.
In response to the question is, can the stem cells be activated by some type of injury? My patient broke the left middle finger, and within about a month, he compared both the left hand and the right hand. And Dr. Salas, this is really interesting, is his left hand is completely got thick hair coming out of his fingers and hands, as opposed to the right hand. And this is an Asian with with dolphin-like skin, and with very, very little hair. And so, does injury modulate the stem cells? And I think the answer is definitely yes. And if you put stem cell in a healthy patient, will it do something? And the answer is, it just depends on what type of injury is. Now, will the stem cell factors like the amniotic fluid for the inflammation, for the cell growth, and for wound healing, will they kick in? And I think it's in terms of the matter of the concentration. If you get put enough in there, I think you can start something in terms of what the body needs. And I think the concentration of those factors can definitely help trigger something into doing something in terms of repair.
Anyone else has any comments?
Yes.
I think we're going to finish up with this panel comments.
Okay, so basically we know that MSC migrate to sites of injury and inflammation. And the migration is
again, because the rest is on the memory, the name of the settlement MSC is present. Now, if you inject with MSC into a mouse with tumor, or mice with an injury, or if you inject it to a body, you see a very different distribution of the cells. The cells are actually in the site of the injury. In the healthy person, you just see them randomly distributed. So there's a very big difference in the distribution, also in the activation. So MSC will be activated by injury, will be activated by inflammation, the alpha will activate them, beta will suppress them. So there are various of factors that affect them. So they are certainly influenced by injury. And if you inject them right after surgery, you will have an effect. They are also very much flexible, and they will vulnerabilities or others will get signals from the bone or from the ligament, and they will differentiate against this image. In addition to that,
Here's my analysis of this. I think that the stem cells function by secreting cytokines and also by multiplying and by replicating and creating more cytokines. It's like a chain reaction. So there's two mechanisms here. There's the stem cells differentiating, maybe repairing tissue, and also secreting cytokines that attract host stem cells in the organs to become more active. So that's one side of it. The other side of it is the immune system. We know that in an immune competent host, that those stem cells will be cleared fairly quickly because they carry HLA identifiable master MLA antigens. And so the intact immune system will destroy those stem cells. They won't be living very long in the host. And so if you have a host that does not have a very competent immune system, those stem cells will probably survive longer and be able to arrive at their targets where they have to go. One word of caution, if somebody is getting chemotherapy and you're giving them allogeneic unmatched stem cells, most of the time you'll get away with it, it'll be safe. But if they're getting really high doses of chemotherapy, and we know this because about 17% of patients that get Taxotere develop neutropenic fevers, you can suppress the immune system enough, the lymphatic system, the immune surveillance, that those stem cells can actually engraft. And there have been cases reported of in patients who are immune compromised getting autologous transplants who were transfused with blood, which contained stem cells from a donor that was not HLA matched, where those stem cells engrafted and caused severe graft versus host disease. So you'll probably get away with it giving stem cells to patients on chemotherapy, but be careful because if those patients are really neutropenic, you can get a rare case of engraftment of those non-HLA matched stem cells, and then you can develop graft versus host disease, which has been reported at Sloan Kettering years back before we knew about all these technologies.
Thank you. I definitely believe that, and it has been proved already, that in the scalp, when you cause an injury via turbo roller, microneedling, it stimulates the stem cells that we at the bulge, and those stem cells reactivate again. So reactivate and start to produce like that hair to become thicker. So they there's a way to videotape the roots of the hairs, and what they saw was that when they create a damage in one of the follicles, the stem cells of the hairs around that damaged hair migrate to that hair to fix it. So that is like an amazing thing that has been proved already. So that's why microneedling and roller in the face, on the scalp, and that becomes very popular. So lasers, especially radiofrequency, fractional CO2 lasers, those just only that creates a intentionally wound that is gonna reactivate and stimulate the production of new collagen and new elastin and tighten the skin and that. But that is part of the whole process of via different ways. But if you add to that the stem cells, you are giving more to that skin to regenerate. And actually, what I'm seeing is that if I'm doing a deep laser, for example, I know that it's gonna take 7 to 10 days to peel off all the scabs and that. But when I have stem cells on board with the therapy, when I applied both therapies, then it's like in 5 days, I have that skin ready. So everything is accelerate the whole process, and my results are better. So I truly believe I'm having also healthy patients. The majority of my patients are healthy. So if I offer stem cells, it's not to cure a disease. If we're doing a more to make the skin thicker and to prevent the aging. We don't want to age. So that's why we're doing it in a preventive way, okay, to keep the stimulation of the collagen and elastin that we know that after 30, we stop producing the rate of the collagen and elastin that we're like normally we're producing. So that's why the fine lines and that's starting to appear at 30. So we're healthy, but we want to, stop that aging process without the need of the plastic surgeon. So now we know the Habib's secret about the stem cells and his face and scalp, like looking younger.
It's a good question. We're still getting it. And as a mathematician, I'm going to rely on a fractal
paradigm to answer it. Because the things our speakers have suggested are all theories. We do not know the answer to what happens after you traumatize the tissue, inject stem cells, and then how does the healing happen. So imagine that, God forbid, a drunk driver drives right into this room right now, and we have a traumatic injury to the building, okay? It's a drunk driver, it's going to be all over social media, especially locally, so that's your immune system. You'll have police here, you'll have all firefighters here, okay? And then, what are your stem cells? You've got to fix this hole in your wall, you've got to get the car out. Okay? The stem cells are your additional workers, your worker bees to do that. For all of this to happen, all these people have to communicate with each other. And so it's the cell-to-cell signaling which is important for the process of repair to occur. So I think we don't pay enough attention to the intercell dynamics of healing. And I think it's multifactorial, and there can be lots of players involved when stem cells are used in the
In closing on this, I think that we're running out of time right now, so they need the room back. I put quarters in the machine and we just run out. In closing, a lot of people here, Dr. Goradia, Dr. Diedrich, Dr. Salas, Dr. Almas, Dr. Brody, Dr. Calilung, Dr. Lamadrid, Dr. Lamblet, and Dr. Gupta. You have my heartfelt gratitude. Thank you so much for being here. Thank you for participating. In closing, before I bring up our fearless leader, I'm going to say thank you to you all for being here. I started by giving you a statement, a little political statement on doing the right thing medically. We have all taken the oath to do no harm. But then we have to have correct science, ethical science. And I've admonished every talk I've given, and everybody's heard me, I admonish you to do the right thing scientifically, collect data, and produce evidence-based medicine. So I leave you with that statement to close us and to lead us into the next event, Habib Torfi.
This was an amazing performance by Dr. Naidoo and his gang of speakers. It was very impressive, as in the opening comments, our promise is that as we roll to the third year of this program, that we want to make sure that this program is scientific in nature, that we are promised to the audiences that we will hear the best in regenerative medicine. Again, all the speakers alluded to the fact that this field is moving fast and furiously in both area of clinical progress and also scientific progress. It would be fair to say that who knows what we are going to hear next October. With that, thank you all. Thank you so much for your participation. Some of you traveled far and wide, and I really enjoy having you here, enjoy having you as a friend, and till next October.
Dinner and cocktails, Habib? Are you offering?
I think you're doing something outside.
We have a short break, and we have cocktails starting at 4:30 outside. Thank you so much.